Thank you, Eamon. And I too would like to acknowledge the lands of the Yagara and Turrbal people. And I would like to acknowledge the protesters. It's entirely appropriate that we should be protesting the importance of U equals U in the beginning of a plenary on HIV elimination. So thank you for your activism. Okay, so in the next 25 minutes, Eamon, this is what I'm going to be trying to cover. I'm going to first talk about words. Words are important about how we're defining getting towards the elimination of HIV transmission. Not the elimination of HIV. There will always be people with HIV with us. The elimination of HIV transmission. I will then be talking about what progress we are making, give an example of somewhere that's doing particularly well, and talk about where we might be heading from there. So what is it exactly that we're aiming for? The gold standard, of course, which we would love to be able to achieve is eradication of HIV, the definition of which is the permanent reduction to zero worldwide. Humanity has only managed this for one condition, and that's smallpox. And unfortunately, HIV is a very different virus. There is no asymptomatic infectious period with smallpox, with smallpox. There is an effective vaccine for smallpox. There is no animal reservoir for smallpox, although, as we saw with mpox in the last year, there are relatives. And smallpox has a very short infectious period and HIV a very long one. So it doesn't appear likely that we will ever be able to eradicate HIV. How about then this word of elimination, the strict definition of which is the reduction of HIV incidence to zero in a defined geographical area? I think most of us believe that this too is not feasible because of the features that I've just outlined. Very long asymptomatic periods of transmission, the lack of a vaccine, and the lack of a cure, which would render all people living with HIV non-infectious for the rest of their lives. But we do, in the last decade or so, we've come to the realisation that we do have two extraordinarily effective prevention strategies. In U equals U, as you just heard, is 100% effective in people who adhere to antiretroviral therapy. PrEP in people who are adherent is very nearly 100% effective, and we're getting new forms which expand the repertoire of PrEP, but they do require adherence. So the question then becomes, if we can't quite get to zero, how close can we get? And this is where UNAIDS has taken a bet, taken a stab, and come up with a goal for us. Of course, the vision, to be visionary, we should always strive towards zero. But the UNAIDS target of ending AIDS as a public health threat by 2030, the transmission, if you like, part of that is a 90% reduction in HIV incidence. It also includes a 90% reduction in AIDS-related deaths. I won't be focusing on that part of the definition today. And that is compared to a baseline of 2010. It's been incorporated in countless strategies around the world, both national and subnational. And I want to make a really simple, some might say simplistic, way of analysing how we're going. Because we are 12 years into that period at the moment, or 60% into that period, that 20-year period of reducing incidence. So if we assume that that incidence was reducing constantly over time, that would be a 54% reduction in incidence. As well as measuring the actual incidence of HIV, UNAIDS has set us tasks in relation to prevention indications. So in terms of treatment as prevention, these have been put together as the 95, 95, 95 goals. There is also another goal, which you hear a little less about, of 95% of people at risk of HIV using combination prevention and 95% coverage for eliminating vertical transmission. If you look at the diagram, you'll see there are also additional parts of this equation about reducing punitive laws, reducing stigma, and reducing gender-based violence. And they're more the settings within this prevention occurs. I would point out that we don't have within this equation, although PrEP is part of combination prevention, we don't have a top-level PrEP target. And I will come back to that because I think the world needs better guidance on what we should be aiming for in terms of PrEP, and I think that would help. So when we dig into these UNAIDS documents, you will find a section of the Global AIDS Strategy which then disaggregates targets by certain populations. And I'm sorry this is a bit complex, but that's the way it is. There are targets for key populations, be they sex workers, men who have sex with men, transgender people, prisoners and others in closed settings, or people who inject drugs. And if we look, and then we have 3 strata, which are HIV incidence strata of very high, high and low, and they do vary depending on the population. But for example, if we looked at this strategy, this group of sex workers at very high risk, the target is 80% receiving PrEP. You will note that the target in low risk people is 0, entirely appropriate. We don't want to be wasting drug in people who are not at risk of HIV. There is also a target for the general population, and again, this is stratified by incidence of HIV, with an emphasis that nobody who's at low risk of HIV should be receiving PrEP. These targets are complex, and regular reporting against these, I would say, is not possible. It's certainly not currently done, and I think that is an issue. So in terms of, let's just summarise then where we are heading for. We've got very specific measurable results around testing, treatment and viral load with annual reporting, and as you'll see in a moment, with very robust systems for monitoring. We're clear about what the decline in HIV we want. We want a decline of 90% by 2030, and there is an increasing ability to report against that. I've said we're kind of clear about combination prevention, and we do say we want 95% of people to be using combination prevention. It is actually, when you look at the definition, it is measurable, but it is complex. You will see in some settings, one of which I'll show you today, there is reporting against this measure. But what we don't really have clarity of in terms of what we're aiming for is PrEP. I believe we need more specific population PrEP targets to enable us to help guide our public health action. So, moving on now to talk about the progress we've seen, and in the first part of this, I'll lean heavily on the very recently published global AIDS updates. So these updates, as you're probably all aware, are based on mathematical modelling. They're not direct measures because it's simply not possible to count the numbers of HIV infections at country level. So UNAIDS, with a broad group of expert partners, builds models to estimate the annual incidence and uses data from a large variety of sources, empirical data from sources, national surveys, cohort-derived incidences when they're available, etc. And they give us what I'm about to show you, these country-based estimates. A real issue with this is that in most countries, there are no estimates in key population groups. We know many of our epidemics are driven in key population groups, but the data that you would feed into a model are just insufficient to be able to develop these country estimates by key population groups. So, in terms of the 95, 95, 95, if you've looked at the report, you will have seen that we're currently at 86% of people with HIV knowing their status, 88% of those being on treatment, and 93% of those having undetectable viral load, for a total of 71% of all people living with HIV worldwide with undetectable viral load. A pretty striking increase since 2015. When we look around the world in terms of global regions, I think we really should acknowledge how extraordinary it is, given the fact that health responses in sub-Saharan Africa started so much later than they have in the rest of the world, that Eastern and Southern Africa is now leading the world in terms of the proportion diagnosed, treated, and with undetectable viral load. An incredible turnaround in the last decade. The data presented in the report on PrEP, as you've already heard from me, I think we need better PrEP targets, but there is a PrEP target to have 10 million people on PrEP by the year 2025, and with few exceptions, we are miles behind that goal. So the general successes of treatment as prevention are not yet being replicated globally, at least for PrEP. And you see, huge gaps between the goals in the red dot and the actual. Again, the places that are doing best are in Africa. Eastern and Southern Africa are about 3/4 of the way there, and Western and Central Africa almost there. So with all of that, new infections are trending down, and they have trended down by 38%. I hope you'll remember from my previous slide that 54% is what we would have expected if we'd had a constant rate of decline towards that 90%. So we are not on track for achieving the UNAIDS goals by 2022. When you look by country here, you'll see this big decline is mostly driven by sub-Saharan Africa, that the infections are decreasing there quite markedly. So the decrease in that region has been 57%, so more than the 54% which would indicate it's on track. Western and Central Africa not far behind. But elsewhere, we see a much more mixed picture. Asia and the Pacific, only a 14% decrease. The Caribbean, similar. In Eastern Europe and Central Africa, we are seeing increasing infections, quite markedly increasing infections. In Middle East and North Africa, based on initially smaller numbers, we are seeing, again, a big increase. Latin America, seeing a small increase, no decline there. And even in Western and Central Europe and North America, the high-income parts of the world, we're seeing a decline that is not on track for those 90% reduction goals. Within those regions, you will have probably heard already at this conference that some countries are doing extremely well with declines of 70% or more. It's countries such as Zimbabwe, Nepal, Lesotho, Rwanda, Eritrea, and others. So some places are showing us how to do it. They're well on the road. In terms of other means of modelling, I do want to single out what PEPFAR is doing in PEPFAR countries in these population-based HIV impact assessments. If we want to really influence policy and where our HIV response needs action, then the sort of detail that these reports contain is incredibly valuable. So these are based on population-based surveys in these studies in PEPFAR countries. This is an example from Malawi where we have 88, 98, extraordinary, and 97, and using detuned incidence assays measuring incidence at the population level, so direct measures of incidence. And here, if you look at 15 to 49-year-old men, you'll see incidence of a little more than 1 in 1,000 per year. In women, 3 in 1,000 per year. And the pattern that we're all too familiar with much higher incidence in young women than in young men. So I think these are the sort of reports we need to really guide policy action. So I wanted to move on from that and now talk about estimates from surveillance. Again, we know that national cohorts are not feasible, but many countries have very well-developed case reporting systems. And where we have situations where HIV testing rates are high and relatively stable, it's likely that these diagnosis rates will approximate incidence rates. You don't see these published in the literature much. You have to go looking on the internet for reports from countries, and they are mostly, not wholly, but mostly from high-income countries. So I wanted to show you a few examples of what we see. In Canada, we've seen a 30% decline, but I would really note that most of this decline is during COVID and may be an artifact of decreasing HIV testing, so clearly not on track. The US has had a 22% decline since 2010, so clearly not on track. But within North America, there are definitely parts of that country which are seeing enormous decline. San Francisco is, of course, the place which first taught us that rolling out treatment and then PrEP to everybody could see big declines. So the decline since 2010 has been 67%, and even more if you take it back to years before. So clearly on track, but a bit of a worry with increasing rates of diagnosis since COVID. New York State, almost on track. England shows very rapidly declining diagnoses, 53% since 2010. And Netherlands are a really remarkable pattern with a big increase, actually, probably because they had inadequate testing in the early epidemic, introduced the testing and had that catch-up, but then a remarkable decline of 68% in men who have sex with men since 2010. Our Australian epidemic, and just to note, this curve goes way back to the beginnings of 1985, shows low numbers and a decline of 39% since 2010, or about 50% if you take it from our peak, which was 2014. And Singapore recently published data suggesting that they're approximately on track. So you can see a huge variety of patterns there, and I should emphasise that many of these are the optimistic places where, as I showed you with the regional estimates, there are many, many places that are not on track to end the epidemic. I wanted to spend the last part of my talk, though, talking about what we're doing where I'm from in New South Wales, where we've opted to adapt the UNAIDS guideline of a 90% reduction and say that we would do it by 2025. We're being extremely ambitious, but we found that to be an energising strategy to take to the community. You're familiar with the 95s. We needed a PrEP target for our location. We felt PrEP was such an important part of our response, and we wanted a target. Given that our epidemic is in MSM, the target we set was that 90% of HIV-negative MSM who have condomless sex with casual partners should be on PrEP. I'm not going to refer again to stigma, but just to say we do recognise that if HIV remains highly stigmatised in subpopulations, we will have great difficulty in reaching this population. And the monitoring strategy we built was underpinned by investment in research, and in this group, which we call HIV PRISM, or for the Prevention Research Implementation Science and Monitoring Project, which really represents how we do things in New South Wales. It's a joint partnership between researchers at the Kirby Institute and the Centre for Social Research and Health and our local health department with the implementers of prevention such as ACON, Positive Life New South Wales and others, and clinical organisations, the Australian Society for HIV Medicine, with some support from the Australian government. So this is what we've seen statewide in New South Wales, a decline of 56%, not very different to the national pattern, but we see that pattern in men who have sex with men and a smaller decline in heterosexuals. When we were noticing these declines, a number of us started to notice that the normal doctors in inner Sydney who were notifying cases were no longer the main places. And so we've used data from surveys and the census to stratify Sydney by the proportion of adult males who are gay. So there's an area in central Sydney where greater than 20% of males are gay, a little ring where it's 5 to 20%, and then the rest of the city and the state, indeed, with less than 5% prevalence. And then we've looked at incidence according to those. So in those less than 5% suburbs, we saw a much smaller decline, 31%. In those intermediate suburbs, the decline was nearly 50%. But in central Sydney, where greater than 20% of the population is gay, we saw a decline of almost 90%, which is, of course, approaching the UNAIDS target of 90% reduction 8 years earlier than we needed to. We're not quite there, but we're almost there. Underlying that, when we saw those patterns, we thought, what is causing that? And so I wanted to briefly present on patterns of access to preventive agents. And these data are from the Gay Community Periodic Survey, coordinated by Martin Holt at the Centre for Social Research in Health. And this survey has been going on since 1996. And in these pictures I'm going to show you of the patterns, I'm going to also show you some of the promotional material which really make HIV preventive behaviours normative in central Sydney. So here you'll see trends since 2015 that HIV testing in the last year has consistently been highest in the centre of gay Sydney, in the greater than 20%, and lower in the less than 5% suburbs, in who we've seen a drop since COVID which has not recovered, something which requires action. In terms of PrEP use over the same time, since we started PrEP in 2016, PrEP use has consistently been higher in inner Sydney, And in COVID again, it stopped increasing in the less than 5%, again requiring action from us. But almost over 80% of men, high-risk gay men on PrEP in central Sydney. And in terms of being on treatment, the contribution of HIV positive people of people with HIV, to prevention, equally high around the state, which was great to see. We've got a good statewide system for treating people with HIV. But when we talk about prevention in New South Wales, we do talk about combination prevention and promote it as such. So it could, condoms are still a perfect form of HIV prevention for those who want to use it. There's PrEP and there's undetectable viral load. And each of these individuals here is promoting a different form of prevention. I'm using this from the Social Research Centre. Again, we call this in New South Wales the rainbow slide, and it's our way of monitoring progress against uptake of combination prevention. So in our outer suburban and rural areas, we see that 76% of men are using at least one method of combination prevention, the yellow being PrEP, this narrow shade of blue being HIV positive with undetectable viral load, and then the others being using condoms or not having anal sex. So it's only these red ones at the top, which are people who are having unprotected anal intercourse without the use of PrEP or undetectable viral load. And you can see in inner Sydney, that sliver of people at risk is substantially narrower, and 87% are using combination prevention. So it appears in New South Wales we are having much more success in the inner city than we are having elsewhere. But it is, and this central area, it's made more remarkable, this decline, by the fact that this is the former epicentre of the Australian HIV epidemic, where at least a few thousand people lost their lives in the 80s and 90s. But it does also highlight that we have a great deal more work to do. And part of this pattern you're seeing by area is underpinned by this. There's patterns by country of birth that in yellow here, we're not seeing declines in men who have sex with men who are born overseas. And we have a particular issue with recently arrived overseas born MSM. So where do we go to next? Where are we up to and where to next? So I completely acknowledge this has been a rather optimistic presentation, but we cannot miss the fact that the world is behind prevention targets by 2030. One region, the East and Southern Africa, is on track, and several data and surveillance data suggests that several high-income countries are on track or close to on track. And I actually believe that if others did this finely grained geographical analysis, it's likely we would find other places that have these larger declines. So as we move forward, we really need to balance these messages of hope that this can be done with the realism that most places are not doing it, and that most of the world is absolutely not on track. But it does show the data. I hope I've convinced you that it can be done when those political and economic choices are made. But I also want to emphasise we are talking about that 90% reduction. If we wanted to get closer to the true goal of elimination, then it's absolutely the case that we need both a vaccine and a cure. In closing, I want to acknowledge a lot of individuals who have influenced my thinking and have also, how do I go back? There, or who have done a lot of work towards making these slides for my presentation. This includes colleagues at the Kirby Institute, Martin Holt from the Centre of Social Research on Health, Matthew Vaughan from ACON, who provided all those wonderful promotional health promotion campaign posters on the slides, and a large number of staff over the years in New South Wales Ministry of Health who are full partners in this research. And last of all, we're just the people monitoring. I really want to pay tribute to the people who have enacted prevention. So all the HIV negative people who take PrEP, all the HIV negative people who test recently, all the HIV negative people using condoms, and very important that we not forget the role of HIV positive people in prevention, all the positive people who have got quickly onto treatment and kept undetectable so they have zero transmission risk. Thank you for your attention.